Right, good evening, everybody. My name is Tim Hardcastle, and I'm the current Vice Chairman of the Association of Surgeons, and it's my absolute privilege to chair this evening's ethics session, which is the second of four for this year. The following two will take place on the 8th of September and the 1st of December, respectively. And obviously they will address various ethical issues that we as surgeons are facing. Tonight's topic is around the ethics of global surgery, and I will shortly introduce our two guest speakers who probably don't need much introduction as they are both fairly well known across South Africa. But before we do that, these ethics sessions are very kindly sponsored through the Genoa Group, and I'm going to give a couple of minutes to Michael Damant to just tell us a little bit about Genoa and what they do and how they link in with the ethics talks. Over to you, Michael. Thank you.
Thank you, Tim, for the introduction. Good evening, everyone, from cold and wintry Johannesburg. I hope you all snuggled up and keeping warm. I'm sure we're all looking forward to a great talk that's going to be delivered shortly. Genoa Underwriting Managers is a liability-focused underwriting management agency. What that means in principle is that we offer both professional indemnity and medical malpractice insurance to a host of different specialities. The company launched our medical malpractice product fairly recently, and are proud to announce that we've amassed over 6,000 medical practitioners in the last about 5 years. The reason for it is because of a number of exciting inclusions that we've incorporated into the product. And yeah, we are very, very pleased to be here this evening and to be able to sponsor and be involved in the talk, a CPD talk of this nature. CPD is something that's very, very important to us here at Genoa. We do events like this very frequently. And should you wish to find out more or hear about additional talks that we'll be offering, please do follow us via our LinkedIn page or alternatively our YouTube channel. A lot of those links can be found on our website, www.genoa.co.za. So without further ado, you guys are not here to listen to me speak this evening, so I'm going to hand back to Tim. We'll then introduce the speakers, and I really look forward to the talk. So thank you very much, Tim.
Information and those links. So we are privileged tonight to hear from Catherine Chu and Salome Maswumi. Catherine is currently the chair of global surgery at the University of Stellenbosch, and Salome in a similar position in global surgery at UCT. Kat trained in the USA, as you will hear from her accent, as a general surgeon and then as a colorectal surgeon, both on the East Coast and the West Coast of the United States, and then had an interest in global surgery and moved across and worked with Médecins Sans Frontières and also in the Department of Health in KZN and other parts of the country and parts of Africa before taking up her current position at the University of Stellenbosch. Salome Maswumi trained as undergraduate medicine at UKZN, went up to Johannesburg to Wits and specialized in obstetrics and gynecology, and then did some international traveling and did a fellowship at Harvard. And then somewhere along the line, there was a PhD that resulted from that. And then subsequently, she's moved back to South Africa and is the professor of global surgery at UCT. And from what I've seen on social media, running a very successful student global surgery group as well, with very enthusiastic students at UCT and I think from across the country, but based at UCT. So tonight there's going to be two different aspects addressed. Catherine is going to go first, and then Salome will go thereafter. And then we'll open the floor for any questions and concerns. And this whole thing of global surgery, as I'm sure you're all aware, is very topical at the moment. And I think even more so in South Africa, because we are in the global environment that is Africa, where a lot of the high-income countries are sending their global support but are we actually contributing, or are we receiving, or are we not doing enough? And I think both of those aspects will be addressed tonight. So without further ado on my side, I'm going to switch my mic off and switch my video off and hand over to Catherine. Thank you very much.
Yeah, thanks a lot, Tim. And I just want to say thank you to the ASA leadership for inviting myself and Salome to speak. I'm going to try to share my slides now. Right, so today's topic, global surgery ethics and challenges. So I always like to start off the global surgery kind of talk with saying that, you know, we know we live in an inequitable world, since we're talking about global here. So this is a map from a satellite at night. And as you can see, certain parts of the world, mostly North America and Europe, light up, and other continents, such as the one we live on, are literally in the dark. But if you look at the global map in a slightly different way, so this is a map of the different continents based on their GDP, or their gross domestic product, which is sort of a proxy crude measure of how much earnings per capita the country's making. And you see that certain continents, North America, Western Europe, and Asia, are overrepresented. But you see our continent, Africa, almost doesn't exist on this map. Let's contrast that now to the trauma burden. So if you look at the trauma burden per capita worldwide, Africa, the continent where we are, is highly inflated compared to the others. And what else do we know in terms of surgical care and the equity and inequities? Well, the ASOS study showed that African mothers are 50 times more likely to die after C-section than moms from high-income countries. And then to bring it back to South Africa, well, we know we live in an unequal nation. And in fact, Time Magazine last year gave us the notoriety of being the most unequal country in the world, specifically our health system, where 85% of the population uses the public health sector, but over half of the resources are in private. And specifically, most of the surgical providers are working in private. But then we know that a third of the global burden of disease can be treated or addressed by surgical care. But unfortunately, 5 billion people worldwide, so more than half the people worldwide, don't have access to safe and timely surgical care when they need it. And most of those people are located in low and middle income countries like South Africa. But on the flip side, surgical conditions kill 6 times more persons annually than HIV, TB, and malaria, 3 conditions here in South Africa that we hear all the time are really important to address. And if you look at funding, you see, for example, that HIV, TB, and malaria have over $4 billion even from the Global Fund annually, whereas surgery receives almost nothing. So that brings me to, what is global surgery? I think people in this room have heard this word and maybe don't know what it is. And I think that, first of all, just to say that the term global health and the term global surgery was kind of given by people in high income countries. And there, to me, there is a little bit of a colonialist kind of attitude inherent in the definition, because if you ask high income folks, what is global surgery? To put it simply, they might say, to go and do surgery in a poorer country, to either provide care or learn about care or get training in a country poorer than my own. But really, to me, or I think that the way we should look at it in South Africa is global surgery is the pursuit of improving access to timely, safe, and affordable surgical care for all people. And when we talk about that, we talk about health equity, social justice, and UHC, or this universal health coverage. And so if you don't know what those terms mean, I'm going to spend a minute or two talking about that. And so in fact, for those clinicians on the call tonight, pretty much we do global surgery on an everyday basis. This is what we do when we see patients, particularly in the public health sector. We know all about lack of resources, and we know that things are not equitable. So you hear this term access to care, and really, what does that mean? So that means the availability of a particular service. So in our case, it means surgical services. And you can think of it in a few different ways. Quality access. So you might have, you might be able to get a C-section, but what's the quality of that? Who's delivering the care? What are the patient outcomes? And then in access, people talk about timeliness. So, access to appendicitis, appendectomy care. I know at Tygerberg the other night, the patient we had for appendectomy was number 69 on the waiting list. So I would say that that is not that timely of care, even if the quality of the service, once you get it, could be quite high. And then the last one is affordability. So for some people in some countries, not being able to pay for the care for surgery is a big problem. Here in South Africa, in the public health sector, not so much. And those of us that work in the public health sector don't really worry about the bills that are generated. For people that are in private or paying out of pocket, it's very different. And then just to mention that in many countries for surgical care, the patient's family would have to go across the road to the pharmacy and buy everything. They have to buy the antibiotics, the surgeon's gloves. If you're doing laparoscopic surgery, they have to buy all the clips and the equipment. They having orthopedic surgery, they need to buy the devices. And so the surgical care becomes unaffordable for many people. And then sometimes you hear these words, inequality, equality, and equity. So I just wanted to spend a moment talking about this. So inequality means that there are basically, there's this example of there's an apple tree and the apples are limited sort of for some people, but not for others. So one person on the screen there doesn't know how to get any apples at all, whoops, where the other one can get it. So my example for that for surgery is there are limited surgical services in all the public sector compared to the private sector. So there is inequality between the public and the private sectors. Equality means that everybody has equal access to the apple tree in theory. So now in the public sector, surgery is now available at all the urban hospitals 24 hours a day, and all people can go to those hospitals if they can get there themselves. But of course, we know that certain people in South Africa live very far from the urban hospitals where most of the surgery occurs. So even though there's equality, there's not equity. And the example here is that some people might need higher ladders than others because the apples are farther away for them to reach, or there are fewer apples on their side of the road or their side of the tree in this example. And then finally, there's the term equity. And so this is the word we use in global surgery, trying to get equitable surgical access for all. So now you're trying to level the playing field. So in the apple tree example, all people are equidistant from the apples, meaning that the person on the right side of the tree has a higher ladder than the person on the left side. And so the example could be surgery is now available at rural and district hospitals, bringing care within 2 hours of every community. So regardless of where you live, you have timely access to surgical care. So I hope that that is somewhat helpful on those definitions because people often talk about those. Okay, so then the next point is to talk about UHC or universal health coverage in the context of surgery. So all of you have heard of the NHI that's coming and people talk about this UHC thing. And sometimes it is a bit confusing about how is it decided what is going to be covered. So if you look at this three-dimensional box here, what's in blue is the current services that are being provided. So you can imagine this is what's being covered. Let's say, this is for the whole country, but let's just take one specific facility. Albert Luthuli and KZN, for example. And so there's different dimensions. The first is the population, who is covered. So, Albert Luthuli may only reach a certain population. That's people that live in KZN or people that live closest to, in Durban, although in theory, they may cover more people. And then the next axis is the services. What services are covered? So, not all public hospitals cover all services. So, is there a vascular service? Is there a robotics surgery service? Is there an esophageal service? Is there a gynae oncology service? Probably not everything, but some things are covered. And so how does one decide in UHC? Because we said surgery for all, what is being covered? So there's obviously some things that are covered and some things that aren't. And then the last thing is the cost. So who's gonna pay? I mean, every surgery, every service has a cost. And so how much does these services cost the system? And I think in South Africa, that's probably the most relevant, because how much it costs to the patient, as I mentioned, is not as into play as possible. So the idea of UHC is to increase this blue area, this blue box, as much as possible, so as much of the population is covered for as many services as possible for the least amount of cost, both cost to the patient and to the system. But of course, we all know that we don't have unlimited money in any health system. And in South Africa, we definitely don't have unlimited funds. So how do we decide? So one of the ways we decide is we look at the cost effectiveness, or the value for money, of each surgical procedure. And that takes into account the amount it costs to deliver the service, so the cost, the impact, so the impact on the particular individual. So for example, would an operation to reduce blindness, like a cataract surgery, how much would that change that patient's quality of life or length of life? Effectiveness, how likely is that surgery going to work? So some operations, okay, maybe spinal surgery, I hope there are no spine surgeons in the audience, but sometimes even the spine surgeons say this is only a 50-50 chance this operation is going to work, but it's going to cost a lot of money. And so that also goes into the equation. And then finally, how many people have this condition? So it might be very effective and it might have a large impact on that particular patient, but it's a very rare condition in the population. So to offer that service, especially in the public sector, may not be one that is at the top of the list. So cost effectiveness is one factor that gets considered, but it's not the only one. And we'll talk a bit more about the other things. So again, to review, so some ethics when we talk about surgical coverage or surgical services. What is best for the individual? What is best for the most number of persons or for the whole population? And then finally, at what level of care should surgical services be provided? And I'll just touch on this because currently most surgical services are in the public sector are offered at regional or tertiary hospitals. And that is where the most specialists of surgeons, anesthetists, and obstetricians and gynecologists are concentrated. So some would argue that the quality of care is highest there, but the number of individuals that can be treated because of the access issues might be less than if this procedure was offered at a lower level hospital, like a district hospital. But then, you know, on the flip side, one might argue that if a non-specialist is delivering that care in a hospital that has not as comprehensive a post-operative care, like critical care, then perhaps the quality is less. So I think those are some of the ethics to consider. So I wanted to go through a few case examples. And I was hoping perhaps to get a little bit of audience participation, but Tim, I actually can't see anyone. So I might just have to shout out random names and ask people. So the first one, the question, I feel like all of us clinicians have gone through this in a public hospital, is if the hospital only has a fixed budget for surgical care, how do we decide what procedures to cover? So Tim, I'm going to pick on you first because I actually can't see anyone else. I don't know if you've ever been involved in these decisions, or what do you think the decision-making process should be?
Well, I think it depends on a couple of things. Firstly, your surgical skill set. So if you've got a specific group of surgeons that are doing what is expected to be done at a certain level, you've got to make sure that what they're doing is that level of care, not you know, if they're in a regional facility, that they should not be doing something that should be done at a center of excellence, for example, where it's got evidence for numbers doing better. At the same time, you've got to look at it really in terms of, I think, what your population needs rather than what you can do. So if your population needs hernia repairs, and then you've got to put money into doing the hernia repairs as electives so that they don't become emergencies. So that kind of decision making is how I would approach it.
Yeah, and those are excellent points. Does anyone else want to comment on that? I see that Willem Smith is on the call. I might try and pick on Willem.
The floor is open, so anyone should be able to unmute.
Dr. Smith, are you there? Do you want to comment at all on how you decide which procedures to cover?
Yes, I'm. Yes, thanks, Prof, for the invitation. I can contribute also just a little bit. In terms of our structure in Upington where I work, obviously COVID destroyed most of the structures we have. And in terms of hernia repairs, I think we don't want patients to complicate. So hernia repairs, that's the one thing. And obviously cholecystectomies, because we had a patient about last week with a perforated gallbladder. She was not on the waiting list for the cholecystectomy, but she was most likely waiting. So this is what I will do. So hernia repairs and cholecystectomies, I think, because this is on our structure here. And also in terms of colorectal things, we most of our patients that we see here come with bowel obstruction because of obstructive colorectal carcinomas. And if we can actually have a system that we can actually do screening colonoscopies, that will obviously source and help with the outcomes. That's my little contribution, Prof. Thanks.
Oh, thank you very much, Willem. Those were great points.
Okay,
thanks. So I mean, I think that there's some really good points that have been brought up. So the skill set of the surgeons, I think the burden of disease has been mentioned of what your population has. But I think it's harder actually when it's two different services vying for the same resources. So I think, within general surgery, I think both the answers are sort of within general surgery. The surgeons themselves may agree on which procedures to focus on. But what about between urologists and general surgeons, or orthopedic surgeons and general surgeons? Because I think that is when the fixed amount of operating time in public sectors is usually one of the limits, maybe more so than the budget. And how do you decide which procedures to cover as a whole hospital? Because I think oftentimes we only think about the firm on which we work. So I just put that for the example, TURPs versus inguinal hernia repair. So even on the elective service, how much elective time should each service get? And I think that is difficult if we don't actually know burden of disease. So what I want to mention is that what you see in your OPD may not be the burden of disease, because for some conditions, patients may not be screened as well, and people may not have equal access to even enter care. And so what you see is not all what's out there, although that can be one argument. So you could have a general surgeon saying, I've got 80 people on my waiting list for inguinal hernia, where you might only have 2 people on the waiting list for TURPs. So I think that is where things start to get a little bit difficult ethically. And, you see clinicians vying for their own patients, which I think is fantastic. Then the next example would be within your own specialty. How do you approach the operation, right? So laparoscopic versus open inguinal hernia repair could be an example. I know Prof. Goldberg is on the call, but I think that laparoscopic versus open colon resection perhaps might be even more of a point of discussion, because it's cost versus patient comfort. The patient goes home one day earlier, but it costs the system more money than the other one, and it might take longer. So in terms of being able to squeeze more operations in at a time, what goes into this decision making? I don't know, Prof. Goldberg, do you want to comment at all on the approach and how a hospital should decide, or a system?
Look, yeah, I wouldn't mind commenting on that. I would think that laparoscopic surgery is great for surgeons, but the gain for patients in colorectal surgery is minimal. The cost has increased. So to me, nice to have, great if you haven't got resource constraints, but absolutely crazy in our environment where I'm probably going to get shot down by someone, where we've got huge issues with providing service. And my take on this is that, you know, the numbers game wins at the end of the day.
Yeah, thanks for that. So I think that you're kind of mentioning the speed or the efficiency of how fast operations can be done. And I think a similar argument has been made at some hospitals in terms of laparoscopic appendectomy at night versus open appendectomy versus, you know, the patient's comfort or one operation being able to see more than others. And I'm sure that that argument now carries into the robotic realm, because I'm sure that you know that robotic surgery has entered the colorectal public sector space as well. Okay, anyway, we won't go into that now. All right, so perhaps the next thing to talk about is that the time that we did prioritization or triage or having to choose between procedures, I think came out very strongly during COVID. Everybody knows that during COVID, almost all surgical services came to a standstill and everyone was doing the bare minimum. But certain places were doing some things. And it was very difficult to decide as a hospital, not as a firm, but as a hospital, what procedures should be done. And, you know, I think there were lots of discussions, debates, sometimes fights between services because everybody's patient is urgent. So one framework that we ended up using here in some hospitals in South Africa looked at 3 different aspects. And I think that these are some things to consider when you have really limited resources. So the first is the disease. So, you know, you ask the surgeon, if we don't operate today, how much is that going to impact the severity, the disease getting worse? So if you don't operate at all, is there a non-operative treatment? So biliary colic, if you don't operate now, is there a non-operative treatment that can be done full stop or be done just to hold the patient over? If you delay for 2 weeks, well, will that change the outcome? So in a cancer patient, for example, will that change the outcome 2 weeks? Probably not. But a 3-month delay? Yeah, probably. But a patient with appendicitis probably is not going to wait 2 weeks. A patient with a femur fracture, again, I'm not an orthopedic surgeon, but they would probably argue not 3 months, maybe 2 weeks. The next item that was under consideration was the procedure. So, you know, during COVID times, we had very few operating theaters and we had very little ward space and ICU space. So the things that we considered was how long does it take to do the operation? Obviously, the faster surgeries got more priority. And then afterwards, where was your patient going to go to recover, the type of anesthesia that you would need, and how long would you stay in hospital, meaning how long would you use up a ward bed? And then the last one, of course, were patient factors, which affects their ASA, their comorbidities, which would affect the patient's outcome. So all of these things were sort of needed to be considered. And so I'm just bringing this up because, you know, now we're not exactly in the same space we were in during the early parts of the pandemic, but we do still need to think about these things when we decide what is the package of care at that hospital if we've only got a certain amount of operation time, a certain amount of budget. Okay, so the next example is, should a procedure, for example, an appendectomy, be covered at the district hospital or a hospital closer to the patient where access is faster and more persons can be theoretically covered? And so I will, let's see, who else can I pick on? What about Damon Bezos? I just see your name right in front of me. So maybe I'll ask you, what do you think? Or maybe Damon just has his, he's just on, but maybe not there. What about Perseverance with the lazy? Would you like to respond to that? How about Andreas?
Sorry, I just went to a bad. The question was?
Sorry?
Sorry, I'm just in, my internet's a bit unstable. Could you just repeat the question?
Oh, yes. Sorry, Damon, not to put you completely on the spot, but I am putting you on the
that's
spot.
fine. I heard
So
part of it, but...
Sure. So one of the questions about, you know, kind of the sharing of resources is, or the ethics around procedures is, should a procedure, and I gave the example in appendectomy, be covered at a district hospital, or I'll say a hospital that's closer to the patient, but perhaps a lower level hospital where the access could be faster because there's less of a drive there, or maybe there's less a theater wait time, and maybe more persons could theoretically be covered, but perhaps the procedure may not be done by the same level of person, or the post-op care may not be exactly the same as in a tertiary hospital. Yeah.
So, I mean, this has been studied in Natal. As I recall, they look to see should appendectomies be done at the peripheral hospital, or should they rather organize a better ambulance service to get the patients to a more central facility. And I think it really depends on how long it's going to take to get the patient there, and how what your transportability is. So if there's a good highway or a reasonable road, that's fine. If it's going to take the patient 5 hours in an ambulance to get there, then you have to train up a lower level of practitioner to be able to do appendectomies and other general surgery. So I think it really depends on how long it's going to take to get patients across and what the ambulance services are like.
Yeah, thanks. And I think you bring up some really good points of the risks and benefits of doing the procedure at that level of hospital. And I'm more or less going to end my talk on this, but I think that this brings up a question that the NHI is asking, and asking us as the surgical community, but kind of what is the basket of care? What type of competencies do people need to provide a certain package of care at a district hospital? And what are we as specialists willing to teach our other colleagues in the medical fields, whatever cater that might be? But also how closely linked as sort of hub and spokes should hospitals of different levels be if we are moving towards this type of model, again, to cover more people safely. I think that's sort of the idea. And I think that's all I had, Tim. Let me just, yes. Oh, and sorry, one more last point, and I won't call anyone, but I'll just mention this. Should common waiting lists across several hospitals for the same condition be created? So we sort of looked at that during COVID as well. So for example, arthroplasties for hips, common lists for breast cancers across, the entire Cape Metro, for example, and for an entire province. Would it be more equitable if patients got on a shared list? Because some hospitals might be doing more volume, which means that if you lived in that health district, you would get that procedure faster. But is that fair to people that live in the other part of the province? And so things to think about, of course, are economy of scale. So, a hospital that does all the cataracts might do it better. And then, of course, the principles of justice and equity. Okay, thank you very much. And I will turn it back over to you, Tim.
Thank you very much, Kat. That was a really interesting discussion and interactive. And without further ado, I'm going to hand over to Salome Mswemi. And again, Salome, feel free to engage with the audience.
Great. Thank you so much. For some reason, it's not allowing me to switch on my video. So if you can just check that from a technical perspective, and then I'll also not allowing me to.
Your video is on according to Zoom. Maybe just turn it off and then turn it back on.
Okay. It says unable to start video, and also not allowing me to share my
see the problem. Okay, try now.
Okay. Let's see. Okay, there. Okay, thank you so much. All right. And I hope you can all see my screen now. So thank you very much, and delighted to be here. I'm going to be talking about global surgery ethics, but more from an academic perspective, as Catherine has covered, mainly the service delivery and other aspects, and also what global surgery is. But I'll just touch on a few things. Often once we decide that, you know, we want to get involved in global surgery, we want to change things, and we start looking outside of the hospital and what else we can do to strengthen the system. And often I end our global surgery lectures and courses with nice quotes like this: change requires more than righteous anger, it requires a program, it requires organizing. But in reality, what also happens sometimes is people run to do things and to implement things that don't always go right. And so today I'm going to talk about the ethics in research, implementation, education, as well as I'll talk a bit about finance as well. And so, I mean, the Lancet Commission gives some really clear recommendations on what we should do. And it's things around strengthening surgical systems, health systems, getting indicators, investment in surgical tools, supporting leaders, advocacy. But in reality, we were not trained. You know, a lot of these things we were not taught or trained in our clinical training. You know, in our specialist training, these things did not come across, and so you find yourself with the zeal to want to make a difference without the tools and the skills to do that. And so it's important just to spend time on understanding, you know, some of the work others have done on implementation and research, and taking a step back before running into implementing things and changing things, but to think of what could go wrong. And then from a health systems perspective, I mean, what global surgery teaches us is we are looking and trying to strengthen surgical health systems. And so whilst all our training is on service delivery and strengthening and improving the quality of our own services, but there are other elements around infrastructure, leadership, human resources, financing, and information. And so just putting that as kind of a backdrop to say, we need to think a lot more comprehensively when it comes to global surgery, but also without, if we don't think about the consequences of what we're doing, sometimes we go wrong. This is often how I look at global surgery, as this interface between surgical care, public health, and public policy. On one hand, you're looking at strengthening the quality and improving the quality of surgical care. On the other hand, you're looking at interventions that you could do from a public health system. And you're also looking at how can you help countries and governments also improve surgical outcomes, ultimately wanting to have healthy cities and people who are healthy. And so the real thing that I want to touch on is these unintended consequences, that as we try to find solutions, as we try to find ways of improving surgical care, that it's important that we understand a few principles. And the one I often refer to is this idea of not trying to find a solution before finding the actual problem. So often one can decide that this is what we think, this is what we want to implement, without stopping to understand what the real problems are and why we've got the adverse outcomes that we've got. And before redirecting services and care and everything, trying to understand how did we get to where we are now, and what would be the context-specific solutions that we can intervene in. And then interventions without measuring, going to implement something, surgical missions, all sorts of things that one can do, but without measuring what is the real impact of what we are doing. And then working on policies that are not implemented is a problem. And then, of course, we all want to do things and tell a good story. Governments want to do that. NGOs want to do that. As clinicians, we want to do that. But it's important that we measure and tell our stories based on evidence. So when it comes to research, the common ethical issues are issues around agenda setting. And as we come up with our research ideas, or whose ideas, whose research are we doing? You know, often, I mean, when I talk about this in the context of high income and low and middle income countries, often you'll find that someone came up with a research idea in another country and then looked for other people from LMICs that can implement this research and become data collectors, etc. But it also happens with us. I could be sitting in Cape Town at UCT, decide that I want data from another place, look around the country, where can we find data, and building partnerships that are not based on need, rather building partnerships based on ideas from more privileged settings. And we want to avoid that. It's doing research collaboratively with people, but not necessarily recognizing them, not putting them as authors, not making them first authors, despite them doing a big chunk of the work, or not communicating and setting reasonable expectations from the beginning, or having this sense of tokenism where there's a grant that says we want people from LMICs, or we want people from vulnerable populations, and then you pick people that are not necessarily going to be involved, but because you need them there, you've putting names there, versus people that are actively engaged in the research that is being done. And sometimes we are often victims of this tokenism as well, because often someone wants an African that they can add to their grant, and you become that person that is now a token, and we need to be careful of that on either way. And then who owns the data? Is this being negotiated? Well, you've done it in your institution, and yet you are not able to use it and access it as you'd like to. The lack of capacity building, where we do research without training researchers on how to do research, and using people as that data collectors versus being collaborators. Capacity building, as I've already mentioned, and then avoiding situations where we set our priorities based on funding. And so you see a call for grants, and that's the research that we're going to do. And then you find people that keep changing their research based on what funding is available, versus doing research that is important for that community. And so we need to ensure that as we do our research, that the overall benefit is to the communities that we are looking after and that we want to make a difference in. The other area is education programs, and in our education programs. And so with all of this, we start looking at how can we increase surgical capacity. And that's when we start coming up with, let's come up with models of training. We'll send our fellows to another country, or fellows will come to our country, or we'll send them to other provinces, to other universities. And sometimes that can be really, sometimes we come up with really good programs that improve outcomes, but sometimes we don't, and we come up with programs that actually cause, more harm in the long run, or don't necessarily benefit the communities for which we are designing these programs. And so with education, I looked at it from both sides, where someone is coming from another country, coming to our institution. You've got local trainees who are competing for experience, and it's not always comfortable. But then you have to imagine yourself also on the other side. If you were going to another country to study, you would also want to be given a fair chance and opportunity to operate, to learn as well. So we just need to look at how we manage those situations. And then also likewise, if people are coming from high income countries, they have never worked in the context of a poorly resourced place. They've never worked with vulnerable populations. They don't understand our languages. In the long run, what does this mean for our patient outcomes? And then there's obviously when you send people for subspecialty training and all sorts of fancy programs, there's always the risk that they might go and not come back. We're not saying that it shouldn't be done, but these are just highlighting some of the challenges that you may experience as you navigate how to improve access to surgical care, especially if you look at it from a surgical training perspective. The idea of training surgeons instead of surgical teams, we all understand that surgeons don't work in isolation. As you train surgeons, you need to train anesthetists, you need to train physiotherapists, occupational therapists, and ensure that you've got an entire team that you are developing, and not just a surgeon. And then we need to be careful with task shifting and sharing. It works in many instances, but it cannot be the only solution. And we need to be very careful, because you do find instances where we've taught certain skills to people that may not be able to manage the complications of doing that surgical procedure. And that's when we end up with adverse outcomes. So it has to be very context specific. It shouldn't be the only way of doing things. And then bringing in fellows, I mean, this is my example, especially with international registrars in a country where we train a lot of other registrars from other African countries. When they are here, they are not funded. We don't often think about their costs of living, what it means to live in another country where you are not always getting enough even to cover your meals and your basic living expenses. And how ethical is that? And how ethical are those programs, and who's monitoring, who's regulating? If you're here for 5-6 years and you don't make it through your exams and you go back to your country, who's monitoring what's happening, the training, the ensuring that people are getting an equitable chance? So it's important that we pay attention and make sure that we are designing fair programs. And then I thought I'll just touch on funding and storytelling, and because it goes well with research and even education, because ultimately these initiatives, these things that we run, we do them because we are able to raise money to do them. But funding can also influence the agenda. If I'm aware that there are funders that are willing to sponsor, for example, cataract surgery, the chances are I'll focus on that versus being in a community where there's a real need for other things. And so we must be careful that funding doesn't redirect our focus, and that we focus on things that are purely based on the money that we have access to versus what the community needs. Of course, there's tokenism also that could be associated with funding. There's reporting bias where we might exaggerate the real impact of what we've done. We've trained one fellow and sharing the news, like, you know, and exaggerating the impact of what it has. Whereas in other places as well, not sharing what you're doing and showing the world what you're doing. You're training 80 registrars a year, but not getting those stories out and showing the successes is also what we don't get right with our storytelling. And this depiction of saviorism, coming into a community, we saved them. They were showing one side of the story, that we found, you know, a dejected community. We went and introduced the program, and now we've saved so many lives. And we need to be careful that how we share our stories is fair, and it doesn't disadvantage the communities and the people that we're talking about, and that we do not reinforce negative stereotypes in what we're doing. So the last part of what I want to talk about is this risk management, because often in global surgery, we all want to do something good. We want to come up with a program. We want to come up with an intervention that ultimately is going to save lives and improve surgical care. But there are various risks, and it's important to understand the risks before you jump in. And so there are programmatic risks where the issue was really in the design of the actual program that you came up with. You didn't do enough research, you didn't coordinate your stakeholders, you didn't monitor, evaluate, measure what you're doing. You didn't collect good data on the quality of your intervention. And so often good ideas fall apart because we did not plan properly and we didn't understand the context of what we were trying to do. There's risks that have to do with money. Everything costs something at the end of the day. So you might have a great intervention, but if it's not funded and if it's not planned properly financially, it won't succeed. There are issues around the quality, coming up with a great intervention, but not planning it properly and ensuring that you've looked at your quality checks of it could be a risk. And then poor leadership and governance and project management as we try to intervene. And so it's important that we mitigate against risk as we try to do all these amazing things and trying to improve ultimately access to surgical care. And as we come up with ideas that are not necessarily our normal ideas that one would have in a clinical setting, we need to look and think differently about how we intervene when we start working with other communities that are not necessarily in the hospital setting or in the theater. Even with managers and governments, we need to think about the risks of our interventions and what we want to do. So in closing, it's really to say that, we all have good intentions. We all want to do well. We want to improve access to care, but there are no quick solutions. There are no simple solutions. There are no free solutions, and there's no single solutions. And so it's important that we do not judge what we do purely on our intentions, but that we look at the results of what we do, and ultimately looking at whether we are really saving lives as we want to do in all that we endeavor to do. Thank you very much.
Wow, thank you both. That was very, very interesting, and I think we've certainly seen the full spectrum of the challenges faced, both locally and in the bigger picture of global surgery and around systems in particular. As many will know, my interest is trauma systems, and I can't but agree. If you train the surgeon to operate and resuscitate, that's fine, but without an anesthetist, without radiology, without rehabilitation, without access through ambulance services and skilled paramedics, and without somewhere to step down your patient when they've survived their major trauma, you're not going to make an impact on returning them to functional and productive lifestyle. So yeah, and I think the other thing we must emphasize is both of you have touched on the ENSOAP. We are still facing the challenge in South Africa that despite supposedly being the more developed part of Africa, we are behind the times when it comes to establishing a national surgical obstetric and anesthesia plan. There's 5 or 6 countries who've gotten there before us, which I think is a real challenge. With that summary, I'm happy to open the floor to questions. I have looked at the chat and I have not seen any questions in the chat. I've also looked at there's no Q&A link. But Trevor, if you say everyone can unmute and ask questions, I think we can happily ask our audience to raise their hands if they have any questions and take it from there. We've got about 7 minutes left, if I look correctly at my time.
Yeah, great. Thank you so much. And ladies, it was most influential, Kat and Salome. I come in here from a risk management and mitigation space, from the medical malpractice space, but I also come in from outside of your industry space. And it's been quite interesting for me in the most recent past to have been involved with a new group that's making some significant inroads into the way that healthcare is handled in South Africa and Southern Africa and Africa for that matter, where inside a 220 square meter facility in space, they are putting multidisciplinary solutions. And I've just been I've had my eyes quite widely opened in this last 4 months while I've been helping them with their risk management, with their insurances, with all of that good stuff, to establish themselves, a crowd called Advanced Medical Center. And the funding that is available to these sorts of alternative healthcare facilities is it's blowing my mind. And we have some of the finest surgeons in the world, but we've got this huge inequality that you speak about, Kat, and I loved your apple tree. I'm going to use that in many of my conversations. And so let me, when you talk about ethics and research and education and funding and sponsors and bias and tokenism, these are real things. And at the end of the day, you guys really are passionate about your surgical ability and the gifts you've been given and the studies you've undertaken to get to where you are, where you can save lives. But we've also got this issue around a new word that I'm learning called languishing. And I'm just wondering how languishing comes into this space of surgery, right between what I think we should be all trying to achieve, which is this thriving environment at the top end of that ladder. If that ladder was a cat of yours was a 10 at the top where you're picking apples and that's thriving, and at the bottom where you're on the ground and there's nothing, let's call that depression. In between we have this languishing, and it leads to all sorts of things that I'm not sure I really understand, but I'm just loving being a part of this journey. We've had some challenges in terms of our own space over this last year and a bit, so it's really nice to reconnect with everyone. And I went to one of the South African orthopedic dinners last week with Michael, and the challenges are massive. They are immense. And I just want to commend you guys as service providers, and thank you for what you're doing. I don't think often enough you get recognized for what you are doing for the community in South Africa, even though the community might be a limited community, even though it may be a differentiated community, even though it may be a segmented community, even though it may be a community where we haven't yet worked out what are our national plans. But kudos to you guys, and I'm just really grateful to Prof in the Free State and to you guys. So yeah, I'm going to bail out at this stage. I've way overcooked myself tonight.
Thanks, Trevor. Thanks for those words. Any questions from the clinicians, maybe from our international audience? I see John Tarpley and Maggie are on the line, and I mean they are in my mind living examples of global surgeons. Any comments from your side?
Krakow from Zambia.
Good to see you. I enjoyed this program very much. I think there were some really good points brought up both by the interactive session with Kat, and really I appreciated what Salome had to say about visitors to host countries and worrying about their housing, and is there going to be any remuneration, and they're not just left hanging high and dry and being exploited. But I think that these are serious challenges. There's actually Kat Chu wrote about this about 5 or 10 years ago, but there's a whole lot of things about neo-colonialism at the present time. There's another article that's just out in Nature this last week, but this is really a very topical subject stateside. So I think that this was a very good ethics hour, and I appreciate ASSA putting this on. So thank you all very much. Good to see all of you, and I wish you well. Tim, I think you're exactly right. System is, I think, the real challenge for us, whether it's oncology or trauma or emergency general surgery or whatever. So keep up your great work, and thank you folks at ASSA.
Thank you very much for your comments, John. Appreciate it. Perseverance, I see a question there from, or you've unmuted. Have you got a question for us or a comment?
Hi, yes, I do have a question. How come we don't have a system where we have your 6 months courses or your 12 months courses? Because this whole thing of waiting for 3 years to write a CSMA exam is just, I think it does discourage it sometimes, because what if you, in those 3 years, you don't get to do some of the procedures? I believe you have to do 160 something procedures before you can write. Why can't we have like the short courses of 6 months, do maybe 30 G-scope, then write, then you move on until you qualify?
It's an interesting thought. Thank you. Some comments from Kat and Salome. In terms of maybe, I know Kat, you've spoken about this before, in terms of rural surgery course, maybe.
Yeah, I mean, I think I cannot speak for the CMSA in terms of the way that they structure the college exams for surgery. I think that the current FCS is the way it is. But I take your point, Perseverance, and the impracticality of people trying to do training with different types of resources, and where perhaps G-scopes might be readily available, but they might have to find another training site to get the colorectal operations in, for example. Yeah, Salome, do you want to speak to that rural surgery diploma idea that we've been thinking about?
Yeah, thank you very much. And thank you, Perseverance. Also, I won't speak up for CMSA. I did FCOG, so I'm the least qualified to talk about how the FCS should be designed. But we've been looking at ideas of how can you, of really having a clinical component to global surgery, and starting to look at having courses for district, for doctors in district hospitals, and designing short courses or diplomas that would have a bit of obstetrics and gynae, have a bit of surgery, have a bit of anesthesia. It's a pipe dream, still quite far down the line, but it's something that we've been thinking that there might really be a need for this if we looking at, at the end of the day, despite all the great training that there is, most of the surgeries done in district hospital, and our adverse outcomes happen there. And if we find ways of improving surgical capacity there, we might be able to make a difference. So throwing it out there, and if you guys think that this is something that we should pursue, we are happy to look further into that.
And especially in the case of time-critical procedures, trauma, emergency general surgery, obstetrics and gynae, and so on. Paul Goldberg had a comment he wanted to make. Paul, over to you.
Thank you, Tim. Actually, I just wanted to thank you for putting a fantastic program together, and for your two speakers who really addressed the topics that we are grappling with. And while I agree that the training of a rural surgeon, of a rural medical officer, or even not a medical officer, even a what are they called?
Specialist family physicians.
No, the Joburg trainees.
Clinical associates.
Clinical associates. I mean, there's absolutely no reason, as in Malawi, that many of them actually do surgery. But are we prepared to go to that level with an independent practice? We already have quite a problem with very expensive and difficult complications from rural hospitals. Now, I'm not sure if that's because people are untrained, or because appendicitis at a rural hospital is not the appendicitis you see in private practice. It's been going for 2 weeks and you've got a belly full of pus and everything's stuck everywhere, and it's not surprising that there are lots of holes. So I think you put together a wonderful program, and thank you very much. And I see Willem Smith has got his hand up from Uppington.
Thanks, Paul. Over to Willem. Hello, Willem. You can unmute.
All right. It's just a last comment about training now. On the 23rd and 24th of June, there's a basic trauma and emergency surgical course that's been held at Tygerberg Hospital. What's interesting about it is that this actually is a basic surgical course in surgery for non-surgeons. Now, our district, we have patients that travels for 400 kilometers. And sometimes we wonder, in terms of the traveling time, shouldn't they just open the abdomen, close the perforated ulcer, and then send the patients? But also, like Prof. Goldberg also said, an appendectomy in Springbok or Calvinia, you can't do a right hemicolectomy. You mustn't do an appendix. And if you get an appendix that ruptures after operation, there's no aftercare. And this is also the issue. so it's a good point, a plan to train the guys out there, but then they must have the skill set. And unfortunately, our ambulance service is also a critical issue. I mean, they will call us in the morning at say 10 o'clock, and the patients arrive here at 10 o'clock at night. And this is the patient.
And we have that same level of distance in Durban, I can assure you.
But that's my experience. Thanks a lot for both talks. I really enjoyed it. Thanks a lot.
Yep. And I
yeah, I'm going to say something again.
Kat's put a comment on the chat. Task sharing will only work with defined scopes of practice. And I think that's an essential point. Paul?
Yeah, just, we're all talking about the problems in Calcinia and in Springbok maybe, where you've got to travel how many hours to Uppington, where the nearest surgeon is? Many.
6 or 8.
Well, yeah, but it could be 8
if
hours.
you think about it, the whole system needs to be upgraded, because if in the private sector you can't get a hysterectomy in the Northern Cape. Actually, they've actually got to go to Bloemfontein for a hysterectomy, and that is shattering. So elective surgery also becomes, somehow hysterectomy is not exactly a big operation. So basic surgical care in Kimberley is missing, or gynecological care. But surely you should be able to get a hyst in Uppington. Why should you go to hyst? What do you think of that, Salome?
Oh, I come from Limpopo, and for me, my reality is when we were growing up, people had to go to Gauteng to get if they had serious operations, or else they're gonna die. And I think now there's a lot more specialists. Our system is revamped, but there's still a lot of adverse outcomes in district hospitals. And I think for me, the heart of all of this is that we don't want a place that cannot provide care for people who need it the most. It's at the end of the day, when my mother-in-law up in Venda needs to go to Johannesburg to get care, there's a problem there. And so we've got a real systems issue that we need to address. And I think all of us coming together like this and supporting each other in this field means we can come up with better solutions and better systems. And I think we in the right direction, even though we don't have all the answers at this point.
Yeah. Well, I think a concluding comment from my side, firstly, is to say a big thank you to both Kat and Salome, and to you at the audience. And then just with this sort of, this thought that comes to my mind wearing my ATLS director's hat is what Jim Steiner said back in 1977, when I can provide better care in the field for my family than what I'm receiving at the hospital, the system is wrong and the system must change. And I think that applies very much across the board in surgical care, not just trauma care. And maybe that kind of be the sort of take-home thought that we can all leave with this evening. And again, thanks to both my speakers and to all of you for attending and participating. I hope you all have a great evening.